So I'll start with my presentation, and that is vitrectomy in retinal detachment. So we saw the importance of laser and pneumatic retinopexy, and now let's dive into straight away vitrectomy in retinal detachment, principles and techniques. It's a big topic, but I'll try and do justice in the next 8 to 10 minutes. So my presentation is divided essentially into 3 parts. What are the indications of vitrectomy in retinal detachment? What are the principles behind achieving success, and the modern vitrectomy techniques and how they've changed our success rate. So indications: when do we opt for vitrectomy versus procedures like pneumatic retinopexy and scleral buckle? First of all, when there is PVR, because if PVR is going to decrease the success of retinal detachment, then you have to get the PVR, the membranes out. There you need to do a vitrectomy. Retinal detachment with accompanying pathologies like, say, vitreous hemorrhage, macular hole, intraocular foreign body, giant retinal tears, or probably a complication of cataract surgeries. In these situations, you are compelled to resort to vitrectomy. In the sutureless vitrectomy area, we have now changing, we are becoming more aggressive towards vitrectomy, because the rehabilitation with sutureless vitrectomy is much better. You want to have lesser amount of red eyes, post-operative edema, proptosis. So probably for cases like, let's say, a superior localized retinal detachment with a single break, which can be buckleable, and pneumatic retinopexy can be done, but you could get away with a sutureless vitrectomy also, because the rehab will be fantastic. So this is debatable. This is an age-long debate. You can always debate, because both will work in these situations. So principles of achieving success. The first cardinal thing is PVD induction, and what helps us in PVD induction, there you can see the nice Weiss's ring. Now this case already has a PVD. You can see the retinal detachment behind. And to achieve PVD induction, we use triamcinolone, and we can apply active or passive suction at the edges of the disc. A forceps sometimes can be used to induce a posterior vitreous detachment. Now you can see here, you have to be very careful. Use low suction, high cutting rate, because the detached retina is right behind, and the PVD has been induced and the vitrectomy has been started. Another one more thing you can use when you're doing this maneuver is put a small bubble of PFCL on the posterior pole of the disc. So it acts as a third surgical hand, and you can do this same vitrectomy or core vitrectomy to start with. The most important thing in vitrectomy for retinal detachment is to do a complete vitrectomy. The rationale being that you don't want residual vitreous remaining behind, because that residual vitreous will act as a scaffold for PVR and will cause a recurrent detachment and will bring down your success rate. So therefore, to achieve complete vitrectomy, you also need to do base excision. Base excision is very easy in maybe aphakic RDs or in pseudophakic RDs. But when it's a phakic RD, sometimes it may be difficult, because at the time of base excision, you could end up having a lens touch. The other place where complete vitrectomy is a challenge is in pediatric and young RDs, young patients with RDs, because over there you have a lot of vitreous, and that vitreous is firmly adherent to the retina. The other important thing is flattening or settling the RD, settling the retinal break. That has to be the endpoint of a retinal detachment. You do that with fluid air exchange. If there is intrinsic contraction and your fluid air exchange is not able to attach the retina, this becomes obvious because air goes behind the retina. In that case, you have to do a relaxing retinotomy to settle or attach the retina. Now, one has to remember that there is really no need for a bone dry subretinal fluid drainage. Once your peripheral retina is attached and your retinal breaks are attached, you could leave back some amount of fluid at the posterior pole, because once you put a tamponade, this residual fluid will get absorbed by the retinal pigment epithelium in the postoperative period. Then doing laser and cryopexy to all the breaks, and this is done after you've done a fluid air exchange, before inserting the tamponade. The various tamponades that we use in retinal detachment, the PFCL, which is essentially a temporary tamponade. You can't leave PFCL for many days after the surgery because it is toxic to the retina, but it acts as a fantastic third surgical tool, where it keeps the retina absolutely stable, keeps the retina back, avoids iatrogenic retinal breaks. In a case like this is a high myope with a giant retinal tear. You can see the retina is rolled over here. We are doing a vitrectomy, and to roll this flap back, PFCL becomes very important. You can see the PFCL bubble being put there, and gradually as you fill the eye with PFCL, the giant retinal flap rolls back. I'm using a instrument to roll the rolled over edge of the giant retinal tear, and once the giant retinal tear will flatten, then we do laser to the edges of the giant retinal tear. Now this is the end of the surgery where you are removing the PFCL while injecting the silicone oil. That is called as PFCL silicone oil exchange. Finally, once the tamponade, the permanent tamponade, you can either use a gas or SF6 in these RDs, or a silicone oil. That is the permanent tamponade, and you do a post-op prone position. The other aspect is whether to put a band or not to put a band. So this is also a debatable thing. When I use a dictum when I'm not happy with the amount of vitrectomy that I've done, when I've left a lot of vitreous in the periphery. In that situation, I usually tend to put a band. Unlike in situations where I'm absolutely sure that I've done a complete vitrectomy. If I'm seeing a lot of PVR and I'm leaving some residual PVR back, there probably I would put a scleral band. If it's an inferior break, because there will be a potential space between the oil and the retina at the 6 o'clock position, there I'll put a band. So these are some of the situations where I put a scleral band or a 240 band along with doing a vitrectomy and tamponade. What has changed the success rate is the sutureless vitrectomy, the high-speed cutters. Now this has made rehabilitation much better. So the advantages of sutureless vitrectomy, where you have a trocar cannula system. Now this is a video from olden times, from 15 years back, where we made these 20 gauge sclerotomies, and at the end of the procedure, we had to clear the vitreous from the sclerotomy to achieve a free flowing sclerotomy. If you didn't do this, then you would end up with iatrogenic breaks. You could have sclerotomy related complications like this. Now what you're seeing here is a retinal break right at the sclerotomy site. This is because of retina getting incarcerated into the sclerotomy, and now I have to tackle that, do fluid air exchange, cryo that retinal break. So these would definitely bring down the success of the surgery. So what you have now is these trocar cannulas, which you insert at the pars plana, you displace the conjunctiva, you insert it, and this gives you a nice clearance, because the inner tube, the inner part of the cannula is quite long and it easily traverses the vitreous base. You have valve trocar cannulas also, which like this is a valve trocar cannula, and the advantage here is this does not allow intraocular hypotony, because you're always worried about intraocular hypotony when you're removing your instruments and putting them back inside the eye. So these valve trocar cannulas also have made life much easier. Like I said, high speed small gauge vitreous cutters, high cutting rate has decreased the surgical time. There are now cutters where the tip is absolutely at the end of the cutter, and that becomes very easy to shave the vitreous, especially from when you're doing vitreous base excision. Another concept which has made life easier is the concept of duty cycle. So what is a duty cycle? Now the duty cycle is, as shown in this animation, is for the same cut rate. Now you can see here, for the same cut rate, this is open for a longer time and this is open for a shorter time. So this becomes a lesser duty cycle, whereas this is a maximum duty cycle. So in the next, you'll see now, you see here, this is used for core vitrectomy, where you want a lot of cutting and suction to happen. You can see how agitated the vitreous is. Whereas this is for shaving the peripheral vitreous near the retina or base excision, where you see how steady the vitreous is. And now actually inside a case, this is a core, into the core mode, where you can see how mobile the retina is. I'm using the core mode to cut the vitreous over a retinal break, and you can see how mobile the vitreous is. But when I shift to the shave mode, there's a shave mode, I'm doing the same maneuver at the same site, and you can see the retina is hardly moving. So these are the kind of techniques which have changed the success rates. So modern vitrectomy, you have better illumination nowadays, you have chandeliers, you have wide angle viewing systems, there's chromovitrectomy, better tamponades, better instruments. So the chandelier also helps in certain situations. Here's a case where I use a chandelier because this was a case where there was an intraocular foreign body which was impacted in a detached retina. Now if I were to yank off the intraocular foreign body from the retina so close to the posterior pole, it would have caused devastating complications. This is my last slide. It would have caused devastating complications. So instead I put a chandelier. You saw me putting the chandelier, and I'm using bimanual, a forceps and a scissor to detach this IOFB from the retina over here, get the intraocular foreign body out. and you can see the foreign body being removed. This is a bubble of PFCL I've put on the posterior pole to keep it safe. There's the foreign body coming out. I've extended my sclerotomy, removing the intraocular foreign body, and then I tackle the remaining retinal detachment by doing laser and putting silicone oil. That's the huge place that, where the foreign body was impacted. So this is the kind of success we achieve with these modern vitrectomy instruments. That's the end.